Hello, and thank you for taking the time to learn more about this important public health strategy plan. Today you will hear from Stephanie Kaminsky, myself, Sharon McClellan, and Stephanie Taggart on a strategic plan designed for national Jewish health that will improve air quality and expand equitable access to respiratory care across Colorado. Poor air quality and limited access to care continue to increase the burden of asthma and COPD in vulnerable communities throughout Colorado. National Jewish Health is well positioned to address this issue due to its nationally recognized leadership in respiratory care, research, and education. In this presentation, we will briefly explain how your organization's mission, vision, and values highlight the stakeholder groups that are central to this strategy. As a nonprofit academic medical center based in Denver, Colorado, National Jewish Health's international status makes it recognized as a specialty clinic and hospital for respiratory care. Since opening in 1899, National Jewish Health has grown as a major institution that combines clinical care, research, and education. Today, National Jewish Health serves patients from across Colorado, the United States, and internationally through advanced pulmonary allergy, immunology, diagnostic, and clinical trial services. This history matters because it shows that National Jewish Health already has the expertise, infrastructure needed to address Colorado's current respiratory health challenges. National Jewish Health's mission to heal, discover, and educate provides the foundation for this strategic plan. This project builds on that mission by emphasizing accessible and environmentally equitable respiratory care for communities affected by poor air quality and structural barriers to care. National Jewish's vision also supports that direction by reinforcing leadership in research and treatment while expanding the focus to prevention, innovation, advocacy, and environmental health equity. This plan also identifies 8 guiding values, including healing, discovery, science, health equity, education, partnership, environmental stewardship, and innovation, which help define what the organization does and how it should serve high-burden communities across Denver County and San Luis Valley.
My name is Stephanie Komasinski, and I will be walking you through the public health problem. Let's start with a quick overview of why National Jewish Health exists. The organization was originally developed for tuberculosis patients in Denver, Colorado to provide respiratory care in a dry, healing climate. All these years later, they are still the only hospital system dedicated to advancing respiratory disorders. Finally, they are currently working on transitional care from reactive approaches to preventative measures. The problem statement for our strategic plan is as follows. Despite Colorado's known reputation for having a safe and healing climate, residents of Denver and the San Luis Valley are subjected to worse air quality, subsequently increasing the prevalence of asthma and COPD. Yet, low-income or minority residents lack the resources necessary to obtain access to the state-of-the-art respiratory care that NJH provides. Moving into a brief history of the issue, Denver and San Luis Valley both have high air quality index rates. High AQI rates can lead to higher rates of chronic conditions like asthma and COPD, and both areas have an estimated 10.4% increase due to the AQI rates. Finally, let's discuss the current challenges which revolve around social determinants of health. Many low-income and minority residents face significant financial strain when it comes to accessing NJH's respiratory care. Additionally, SDOH challenges can manifest through accessibility issues due to a lack of reliable transportation to get to appointments.
This strategic plan depends on strong stakeholder engagement because improving air quality and access to care cannot be achieved by a single organization alone. Key stakeholders include patients and families with asthma or COPD, National Jewish Health leadership and staff, community health providers, health safety net clinics, state and local agencies, schools, community organizations, and funding partners. Each group plays a different role, from sharing lived experiences to supporting implementation, outreach, coordination, policy alignment, and long-term sustainability. Because their power and interests differ, engagement must also differ, with high-power stakeholders involved in planning and metrics, while community groups engage through advisory boards, focus groups, education, and co-designed interventions with individuals and families that suffer from COPD or asthma.
Hi all, my name is Stephanie Taggart, and I will be taking you through our environmental scan and pestle analysis. Colorado's air quality crisis is happening right now. BP reclassified the Denver Front Range to a higher ozone non-attainment status in 2024, and the communities absorbing the worst of it are Latino, Indigenous, and low-income residents who already face the greatest barriers to care. Rising costs lock people out of specialty respiratory services. Broadband gaps in the San Luis Valley limit what technology can even do. This environmental scan tells us exactly who is being harmed, why, and where NJH has both the responsibility and the opportunity to act. Pestle analysis breaks that landscape into 6 strategic forces. Politically, Colorado's ozone crisis has opened a policy window, and NJH is positioned to be the scientific voice in that room. Economically, financial instability directly predicts COPD, which means access and affordability are clinical priorities, not just social ones. Socially, language barriers and limited health literacy delay care for the populations with the highest disease burden. Technologically, telehealth can expand reach, but only if we pair it with device lending and digital inclusion to prevent it from widening the gap. Environmentally, Denver's failing AQI grade and the legacy of historic redlining demand we treat this as an equity issue, not just a clinical one. And legally, social determinants of health, housing, income, education, and transportation are the documented root drivers of respiratory disparity in Colorado.
SWOT analysis. The internal strengths of the strategic plan include NJH's mission and vision revolving around fostering community trust and reliance on robust research infrastructure that can lead to better healthcare outcomes for patients. Again, their integrated model of care and health education systems allow for the delivery of community-based air quality literacy to hard-to-reach populations. The internal weaknesses include NJH's recent discontinuation of DEI programs, bringing into question the prioritization of equitable care for minority populations. Additionally, there is known clinical distrust in vulnerable populations, and the issue of SDOH barriers like cost and the location of NJH's facilities is prevalent. The external opportunities include the potential for an increase in equitable health care for minority and underserved populations. This change can therefore lead to an increase in better health outcomes as a direct result of increased access and affordability to care. Finally, the external threats of the strategic plan include continued SDOH threats like financial strain or social/cultural barriers, because a successful strategic plan is only successful if the target population can access and afford the services the strategic plan is advocating for. Additionally, the potential for higher AQI rates and a higher prevalence of COPD or asthma would lead to renegotiation of the plan itself, likely needing to shift towards risk management.
3 priorities drive this plan. First, health literacy. Communities that understand their risks make better decisions and use fewer emergency resources. Culturally, responsive education is both equitable and cost effective. Second, expanded access with technology and innovation through FQHC partnerships, sliding scale services, and mobile screenings are executable within 1 year. Third, policy engagement. NJH must be at the table shaping air quality standards, not just treating the patients harmed by them. These 3 priorities align with our mission, our data, and our community's urgent needs. All of these are not just aspirational. Every target is measurable, and Stephanie K. will explain how next.
The SMART goals are listed below and are designed to be achieved by June 30th, 2027. 1. Implement a 6-month-long health literacy program with 150 residents, with 75% of participants having a 10% increase in health literacy rates through the use of a chronic respiratory disease health literacy tool and pre- and post-tests. 2. Establish 2 community-based respiratory care access points, enroll 150 patients in a sliding scale, and hold 2 mobile screening events serving at least 30 patients each through the help of local partnerships and collaboration. Finally, the last goal has 2 defined deadlines. By December 31st, 2026, the project will establish a partnership and submit 3 or more policy recommendations to decision makers. By June 30th, 2027, the policy efforts will be used to expand community solar access for the target population, reducing fossil fuel use and supporting healthy indoor air.
Bringing these 3 goals to life, our implementation plan addresses staffing, funding, partnerships, barriers, and sustainability. Staffing is goal specific. Bilingual community health workers and health educators for goal number 1, telehealth coordinators and mobile clinic nurses for goal number 2, and a policy analyst and lobbyist partner for goal 3, every role tied to objective level metrics. Funding is diversified across federal CDC and EPA grants, state Colorado Department of Public Health and Environment resources, philanthropic support, and Medicaid managed care contracts. Partnerships are named and contracted. The Colorado Health Literacy Coalition, FQHCs, Earth Justice, and the San Luis Valley Rural Electric Co-op. We've identified the barriers: language, geography, political risk, and the community trust challenge created by NJH's recent DEI rollback, and we're managing them through quarterly risk registers with assigned owners. Lastly, sustainability is built from the start. Medicaid contracting for the literacy tool, EHR integrated FQHC agreements, and a standing, not time-limited policy advisory committee. We measure everything and we use what we find. Process evaluation runs quarterly. Sessions delivered, partnerships formalized, screenings held, patients enrolled, testimonies submitted, and all reviewed by NJH leadership to course correct in real time. The short-term outcomes at 3 to 6 months will be in place to measure literacy gains, patients enrolled in care, and policy recommendations are submitted. The long-term outcomes are at 12 months: sustained self-management behavior, reduced emergency department visits for asthma and COPD, and adoption of at least one NJH-supported ozone policy in a high-burden community. We're using 3 framework sequences: the CDC logic model to make our theory of change explicit at design, re-aim at 6 months to surface who is and who is not benefiting, and the CDC evaluation framework throughout to ensure findings are used, not just reported. Now handing off back to Stephanie K. to review the plan's budget.
Here you will find our preliminary budget, which includes items for personnel, program/operational costs, consultant services, marketing, evaluation activities, and indirect costs. We look forward to viewing your presentations, welcome your feedback, and thank you for watching.